so I don't want to take too deep of dive on some of this stuff, but the disorders of liver, this all going to get through these 54 slides today. I'm sticking with glide path with what Major Kelly proposed as far as schedule and canvas. Mr. Mercer will be in the hot seat next year for GI, so I'm not going to put a lot of effort into something I'm going to have an N of 1 over. I'm ready to bring it for you guys for GMed next semester. So disorders of the liver, general overview. It's just a picture to talk about what we're getting into. We're going to focus a little bit in that right upper quadrant and have a little bit more better understanding of this. When you do come to senior semester, we are going to teach you ultrasound, specifically the EFAST portion of that. It's something that transitions, is something you get to look forward to. I'm sure there's a couple of folks out there that are savvy with ultrasound. You're going to need to get it because you're probably going to be fielded with that at your Roll 180 station in the future at some point. It keeps getting pushed right. I hope they're going to go with a certain model because I've tested all 5 of them. But you know, the military is lowest bidder. So good luck. But at least be good on EFAST, be good on doing an ocular ultrasound, be good on doing a deep vein thrombosis scan, and then potentially looking at some soft tissues and then vascular access. But I digress. So we'll get into the anatomy of the liver. So just for your visuals, so we're clear on what we're going to talk about. We're going to get into a little bit of discussing gallbladder and talking about liver function tests. But this is just precursor to explain to you. The liver's got a very interesting way of blood flow to it. So you have blood flowing in the liver through 2 main vessels. Right here you have the portal vein, which brings nutrient-rich deoxygenated blood from the intestine, stomach, spleen, pancreas, and hepatic artery, which supplies oxygenated blood from the aorta. So portal vein provides about 75% of that blood. The hepatic artery provides you about the other 25%. Now, that's just a windage amount, but just to give you an idea, after circulating through the liver to be processed and filtered, the blood exits through the hepatic veins, which drain into the inferior vena cava and ultimately return to the heart via the right atrium. So just a quick review there on that. No test on anything like that. Make it pretty clear on what I want you to have an idea of. A lot of that's going to be really focused on jaundice as well as liver function test and what it was meaning. So liver has a lot of functions. People forget that. It's like the pancreas, like, well, it just secretes bile, right? No, well, it does a whole bunch of things. Particularly taking all these different carbohydrates like protein and helping turn them into energy for metabolism. We have synthesis of bile, salts, and acids because what does the liver create? Liver creates bile, which helps with digestion of fats. Also activation of vitamin D, metabolism of drugs and hormones. That's going to be very important when we talk about liver toxicity. Then we also talk about the excretion of bilirubin. Also important for storage, and then phagocytosis. So what is phagocytosis? What exactly is that? So it's basically clears pathogens. That's what the liver does, helps clean up all that stuff. Red blood cells plays a big role in breaking down other types of dead cells, clearing debris from the blood. That includes alcohol, regulating inflammation, and promoting tissue repair after injury. So that's kind of a few parts there. But one of the big things that it creates right there is bile. Okay, secreted by hepatocytes. So we're looking anywhere from 800 to 1,000 milliliters. So almost a full liter. I'm going to break that down. So bile, yellowish, brownish, olive green liquid that comes out of the liver via the hepatic duct and then ends up going in the cystic duct and then gets stored and concentrated in the gallbladder. And then what does the gallbladder do? It's going to excrete that. That's why when we eat, it's going to cause the gallbladder to contract, push that bile out that's been stored and help out with dispersion and digestion of fat. Everybody tracking on that? All right. And we have the sweet bilirubin stuff. So that is from the breakdown of RBCs. So releases iron and globin that's recycled, and then the bilirubin is a byproduct of that. So also gets secreted in bile from the liver as long as the liver is functioning properly, and then it becomes a good measure of liver function. So, and we're going to get into that whole conjugated, unconjugated bilirubin, aka direct or indirect, based on what book you read. Have an idea of that. Everybody remember all this stuff back from anatomy physiology. Just a quick once over. You have your unconjugated bilirubin, is water-soluble form produced from the breakdown of red blood cells. But you got your conjugated, is water-soluble form created by the liver when it attaches this special acid, glucuronic acid, to unconjugated bilirubin. So this becomes important because when we're trying to figure out what's going on with the liver and where the damage is occurring, we need to know if it's pre-hepatic or it's happening at the hepatocellular level, or then if it's happening from obstruction, which is going to be post-hepatic. You can almost break that down into unconjugated, being pre-hepatic because it's usually from hemolysis, into hepatocellular, which is going to be a combination of unconjugated and conjugated. And then if it's obstructed, it's probably going to be conjugated. So just to give you an idea of how that kind of works as that processes itself through the liver. So we get concerned about the key difference with this unconjugated bilirubin. It must be transported by albumin and can be toxic in the brain at high levels. That's when we're talking about newborns. When we check their jaundice scale, that's because we're making sure that albumin has to start transporting that unconjugated bilirubin, or it goes too high, we need that to start clearing. That's what we get concerned about when we have little kiddos. So that stuff is, talk about conjugated bilirubin can be excreted in bile, is not toxic in the same manner, So clinical practice, we say liver function test, well that's kind of a misnomer. Because these aren't actually markers that represent how well the liver is functioning. It really is markers to let us know how the liver is not functioning, if they are elevated or they are off. So they are actually markers of hepatocellular injury or cholestatic disease. And we say cholestatic disease because that could be anything that has to do with the biliary system. Okay? Not just cholecystasis, which is just, that's kind of backing up. It's not just cholelithiasis, but cholecystitis, right? So when the gallbladder is inflamed and it needs to come out, no case of cholecystitis goes home. You don't send that home. But then we also have what is choledocholithiasis. Anybody have any clue what that is? That's a big obstruction. We get a stone that goes through the cystic duct and into the common bile duct. And that backs up liver and it backs up the gallbladder. So we get concerned about that. So we're going to look at these markers. We're going to take a deeper dive into that. So here's your basic markers. So we have our aminotransferases, our ALT and AST. We also throw in alkaline phosphatase. We're also looking at protein, and then bilirubin and albumin as well. And these are all markers typically that we need to check. If they're in good standing and they're within their normal limits, we don't get too concerned. But they can be markers for things that are going on. Give us an idea that something's not right with the liver or the biliary tract. So we have our GGT as well. We have our lactated dehydrogenase, and then prothrombin. Why? Because that's an important function of the liver. What does prothrombin run with? Is it intrinsic or extrinsic as far as the cascade pathway? I remember that, PT. Where do you do PT at? Outside, extrinsic. There we go. Extrinsic. And then it's also going to run with INRs, so vitamin K is all important with that. So worry about platelets. Here's your normal values. No, I'm not going to expect you to that. We ask you questions on that. We usually are going to give you the parameters so you know what normal is. By the way, when you pull it up on your computer on Genesis when you're in practice, it's going to give you your reference ranges too, and it'll say which is high, which is low. It's concerning. But I want to make sure if we're worried about hepatocellular, then we're going to see increases in AST and ALT. Now it's going to get crazy with this. We need to have an idea of how this works as far as our hepatocellular pattern, but disappropriate elevations in these give us an idea compared to the alk phos. So we're going to see these elevated, not alk phos, when we're dealing with hepatocellular. So ALT found primarily in liver, where AST is also found in skeletal muscle and erythrocytes. So what does that mean? ALT is more specific for hepatic injury. So we want to look at that a little bit closer when we're talking about the liver. We're talking about the liver. So, but when we see these elevated, unfortunately, your differential should be like out here, 180 degrees. A lot of different disease processes. It's not specific for exactly what's happening. Exactly what's happening. We use all of our clinical acumen. So making sure we're asking all those questions, our OPPQ or ST or sample history, good physical examination. Maybe they need repeat labs to see how the disease progression. We look at hepatitis panel. We'll get into that a little bit more in the next lecture. As far as we look for, and then hepatic ultrasound, also known as any idea? What area are we looking at for looking hepatic ultrasound? So right upper quadrant ultrasound, ruckus. Right upper quadrant ultrasound, because we're also going to look at gallbladder. We're just going to look at that whole area. And if it's a formal done by any ultrasound techs in this class? I've had a couple classes that had some ultrasound techs, so I understand that. They get pretty savvy at that. The amount of reps that they have to have. And then we can't figure it out, but at least we did our due diligence. We're not going to put a consult into GI. Put a consult into GI. This is definitely very important. I would definitely know this. If we're worried about alcohol-related liver disease, what we're going to see with that specifically is that AST is going to be double that of the ALT. Okay, and then we're also going to look at that GGT because it should also be elevated too. So we're going to see AST double the ALT, 2-to-1 elevation. We're going to see elevated GGT. Should see that in alcohol liver disease. Some people have amazing livers. They don't have to tell them to shut up. You're fine. You keep drinking. But this is what you should see these folks. So AST and GGT elevated. Now, when we get a pathophys of this, I don't really need you to know that. Just know that a lot of these people, so it has to do with they are B6 deficient. Well, they're B6 deficient most of the reason, not because they have this inherited genetic disorder. It's because they drink so much that they're having malabsorption. They're not taking enough vitamin in. They're not taking enough B6 in. And if they don't take enough B6 in, and they have that deficiency, that's going to cause that ALT to decrease. The ALT decreases when they don't have enough B6. Does that make sense to everyone? That's why the AST is going to increase, the ALT decreases. AST increases in GGT. Okay? Now, GGT is also not a very specific type of thing. So, present in hepatocytes, also biliary epithelial cells, also found in the renal tubules and the pancreas and the intestine. So this can be elevated. It can be an issue with any number of these organs. So similar to our alk phos that we talked about, similar to alk phos. So gives us an idea. Here's what it's also elevated in with GGT, which is why you can't just say, oh, GGT is elevated, it's got to be alcohol. Doesn't necessarily. It can also be from chronic obstructive pulmonary disease, so COPDers are going to have an increase in this, as well as people that have renal failure. So it can be a sign of liver, bile duct damage, but it can also be caused by other issues. Alcohol consumption, even certain medications and other health conditions that we talked about right here. Talk about this a little bit more regardless of the cause, could be responsible for that. Highly sensitive for liver disease, but lacks the specificity. So we just want to be careful with that. But again, AST greater than ALT by 2 times. GGT should support that, can support the diagnosis of chronic liver disease. chronic from alcohol. And then how does it all progress? Everybody's tracking how that progresses. Portal hypertension happens, then they get varices, then they have upper GI bleeds, and it's a whole mess after that. It's a whole mess after that. So we try and get people to take care of their bodies better. We'll take a little bit of a deeper dive into what we're going to see with cholecystatic patterns. So this is more obstructive types of things dealing with the gallbladder. Very important that you know this. I guarantee you're going to get pimped on this in your surgery rotation. If you get to sit through a lap cholecystectomy, they're going to pimp you on, well, where's the hepatic duct? Where's the cystic duct? Where's the cystic artery? That's called the triangle of Callot. And if you don't get on the ball with that, they're not going to let you do anything else after. You're going to sit there and hold the camera. And that sucks, just standing there holding the camera for hours upon hours. But that's what we're going to talk about there. So what do we see when we have obstructive cholecystatic patterns? Compared to the serum aminotransferases, we're going to have an increase in alk phos. Obstructive pattern, alk phos is going to be through the roof. So if I were to give you a bunch of labs, you're going to pick the one that has the highest alk phos. We're concerned about that cholecystatic pattern. So how does that happen? So this hepatic ALP is present on the surface of the bile duct epithelium. So when that ALT releases, it increases the accumulating bile salts, which unfortunately causes what? In the gallbladder? Gallstones. That's how they get started. So, but we also need to be careful with that because that can also be related to bone diseases. So let's say we don't see an increase in AST and ALT and just an alk phos, maybe we just need to be concerned that that's a bone disease, an underlying bone disease. So in the absence of that, if we cannot confirm that it's hepatic origin, so we're going to get that GGT level as well. So normal GGT and elevated alk phos should make us think that this is not a hepatic issue, this is a bone issue. It's coming from the bone. Take a deeper dive now in jaundice, an appropriate slide there, very appropriate. So, also known as icterus. What is that from? Increase in bilirubin. Now, is that from direct or indirect bilirubin? Both. Both. It could be from both. It all just depends on where that process is. So don't get wrapped around the axle that it's only direct and it's only indirect that causes that. It can be from both. It's ultimately what is the cause and where is that happening? Is that prehepatic? Is that hepatocellular, or is it obstruction? So all three of those can cause that. And I told you prehepatic is likely going to be unconjugated. Hepatocellular is going to be conjugated and unconjugated. And then after that, it's probably going to be conjugated. Just to give you an idea of that. That's basically how that works. But serum bilirubin above 2. So where does it show up first? Well, it's in the eyes. And in the eyes. Visually, where does that show up first, I should say. So visually. Here's an example of what that looks like. And here's your scleral icterus. That's where that should show up first. Where it should show up first. If it's starting to show up in the skin, it should have already shown up in the sclera. And I've had people come in, I'm like, Ryan, I don't know what's going on with you. I'm going to run out of labs. You're definitely getting bitten because you should not have that issue. And I'm just wondering at what level and where is that specifically coming from? Am I going to order a direct and indirect bilirubin? That's going to give me a much better idea of where that's occurring. If both levels are up, I'm like, that's definitely at the hepatocellular level. If it's unconjugated, I'm thinking, well, it's probably newborn, but that means there's significant hemolysis going on in their body. And then if I have a high conjugated and not unconjugated, then I'm like, this is probably obstruction somewhere. Plus, I should have an elevated alk phos. So, idea of that, that's where we use all that. Right there. I was talking about, we got to characterize that to have an idea. Well, we can't exactly characterize it until we have direct and indirect bilirubins and we have LFTs to have an idea of what's going on there. And I told you how those all kind of fit in there with the unconjugated and conjugated. Everybody checking on that? Good. It's like, this is a slide that's kind of like the Krebs cycle. The slide just needs to stay there, but understand again, direct bilirubin is water soluble, also known as conjugated. It's been processed by the liver, it's conjugated, processed by the liver, indirect bilirubin, fat soluble, product of red blood cell breakdown mostly. So liver helps transfer that from unconjugated to conjugated as long as it is functioning properly. So let's break those down. We have our unconjugated because we've got the lab. So plasma elevation, predominantly unconjugated. There's maybe an overproduction of bilirubin, or it's not being uptaken by the liver. So, or there's problems with the conjugation of that. Another slide here, increased bilirubin. We have unconjugated hyperbilirubinemia. So what I say, above a level of what? 2. Good. So hemolytic anemias, hemolytic reactions, hematomas, pulmonary infarctions. Yeah, I'm going to work this up probably about that much, and then I'm going to get an ultrasound, just for good measure, and then I'm going to send this person to a GI doctor. So it's like Doc Schmidt was just clowning the ER about that stuff. They do that, that's fine. I don't mind if I call them one time, if I call them twice in the same day for the same issue and I didn't learn my lesson the first time, then they can clown me. But then we have impaired bilirubin uptake and storage. So this is typically going to be post-hepatic in nature. And then we have these very interesting syndromes, things like Gilbert, Craiger-Nahar syndrome, and we worry about drug reactions as well, because a lot of things are processed by the liver. And then, so we can have both unconjugated and conjugated bilirubin. Typically, like I said, hepatocellular disease, but it can also be lack of excretion or biliary obstruction. Again, these can kind of run together. If you think about that, if you do have an obstruction, you're doing damage to the liver. So you need to be careful about that. But you're going to get those levels checked. So conjugated hepatocellular can be hepatitis cirrhosis related. There's choledocholithiasis. Again, that's a stone in the common bile duct. And we have things like biliary atresia, as well as carcinoma, and then these random hereditary cholestatic syndromes. Here's what unconjugated is going to look like. Typically, it's mild jaundice. Normal stool, urine color. Those are not going to be changed. There's no bilirubin in the urine then. No bilirubin, because it has to figure out how it's going to excrete it. It's going to excrete it through the kidneys. So splenomegaly can also be an underlying cause of this. If it's conjugated, here's how this shows up. So again, we see these people are jaundice, they have malaise, they don't want to eat, sometimes low-grade fevers. So right upper quadrant discomfort, dark urine. Females can suffer from lack of menstrual cycle, the pulmonary emphysema, ascites. I see this a lot in chronic alcoholics. Chronic alcoholics are going to present a little bit more like this. And then you have your cholecystatic, that's conjugated. We talked about that. So jaundice. They're also going to complain of itching. So they are super jaundiced and they have this underlying pruritus, that is just a medical term for itching, and then light colored stools. Now I want you to pay attention to this one, and this one's going to be a little bit more important. If it's conjugated biliary obstruction, jaundice, right upper quadrant pain, weight loss, pruritus, they're going to have dark urine, but the stool is going to be lighter in nature. Why? Because that bile, the bilirubin and everything with the bile is not getting excreted into the GI tract. Does that make sense?
Yes.
Well, it's in the blood. Well, what filters the blood?
Kidneys.
Kidneys. So obviously it's going to end up there. So I have to get to that level where I understand things. Just makes more sense. So we work that up. We want to get a CBC. We want to make sure there's no underlying anemia, no evidence for leukocytosis, CMP-UA, and then we reach for that hepatic ultrasound, also known as the right upper quadrant ultrasound, and then potentially for an ERCP. ERCP, this is a diagnostic and therapeutic. That's obstruction is suspected. How do they do that? Right here, endoscopy technique. They go into the bile and pancreatic ducts. If they find a stone or obstruction in there, they can potentially take care of that with the ERCP. Now, does this ERCP also run a risk of causing a cholecystitis in the future? Absolutely. They can go in there and do a little too much damage. About 5% of those are going to come out and end up with a cholecystitis. That just means they have to go in there after the ERCP. That's taken care of. Well, now they're going to take the gallbladder. So, for you visual folks who just wonder how they do that, essentially how they're going to go in and extract that, usually diagnostic and therapeutic procedure. So hopefully they have the right etiology with that. So if you can't get what the jaundice is being figured out, we're going to send them to see a GI doctor. If you want this broken down a little bit easier, because some people out there just do better with charts, this is a pretty sweet chart. Remember, I broke it down to you, pre-hepatic, unconjugated. Hepatic is conjugated and unconjugated. Post-hepatic, if you can get that concept down to where those three are, you can probably do just fine on any PANCE question that they're going to give you. Any PANCE question that they're going to give you. So you just see we have our ideas where we know where the dark colored urine, the clay colored stools are going to happen. At your ALP levels, but it's just for your visual folks. Questions on jaundice? Questions on jaundice? All right. There's a little bit more in my realm of emergency medicine with toxic liver injuries. The liver helps clean up all the blood. So it's going to take a lot of things to get filtered through there. Number one we need to be worried about is acetaminophen, aka Tylenol. If it takes too much Tylenol, sometimes intentional, sometimes non-intentional. People are older, they just keep taking more and more. Look at our statins, our NSAIDs, antibiotics, some over-the-counter medications, supplements. We do get concerned if somebody is drinking a lot, but they're also taking a lot of Tylenol because they're in pain. The combination of those two things are going to be filtered through the liver, so we don't want to overwork the liver. Tylenol and alcohol is just a bad combination. Bad combination. So, right here, pathogenesis pattern, we have direct hepatotoxicity, usually a dose related, and we're specifically going to get into Tylenol and discussing that. Very important that you understand what a latent period after exposure is. So there's a time to burst when they get exposed to the particular type of thing and to when it actually does damage. That's all that means by latent period. Latent period. So what does that mean for Tylenol? I'll explain that usually about the 4-hour mark. About the 4-hour mark, and I'll show you a little chart in a nomogram for that. And then we have this weird thing with the liver's a wonky organ, so idiosyncratic reaction is a rare, unpredictable adverse response to a substance that has nothing to do with how much substance is in the body. The liver just does not like it, or it can be related to a disease process. So things like Stevens-Johnson syndrome, DRESS syndrome, toxic epidermal necrosis. Just for whatever reason, the liver does not like those three diseases, and it'll take a hit. It'll take a hit from any one of those three. What we need to be concerned about, and why is this one of the most dangerous drugs in your arsenal? Because you can go buy it at any store. Most people have it in their home. So this is a horrible, horrible way to die. And some people will go and they'll dump it down there. That's why we check any overdose we're concerned about. Any suicidal person comes in, we're going to check an aspirin level, we're going to check a Tylenol level, and probably do a urine drug screen. But the Tylenol and aspirin level are about the only two that we can work with. So Tylenol toxicity, what did we give for that? I'll show it in the next slide. NAC. Tastes pretty horrible. Tastes pretty horrible, but it's going to be very needed because they're going to have fulminant hepatitis, and then they circle the drain for a week before they go down. It's bad. So please stay away from that. Tylenol is a horrible thing. So what's max dose? Tylenol you should be able to take in a 24-hour period? 4 grams. Thank you. 4 grams. I'll go 4 grams. I have some older people that just they've got a bad headache, they just keep popping Tylenol, So we use our Rumac Matthew nomogram, and I'll show you that in this next slide. And we treat that with NAC. Now we want to have an idea of like, when did you take the medication? Because we need to be past the 4-hour mark when we order that Tylenol level. Why? Because this chart says so. What am I looking at that 4-hour mark? If it's above 150, NAC better get going, or the liver's gonna die, and then they are too. Gotta reach for the NAC. Other types of toxic liver injuries, we have hepatocellular that relate to hepatitis. We'll get into that next slide. And then we have all our cholestatic injuries. We have our non-inflammatory, which is typically maybe just some, so we can have what's called biliary dyskinesia, where the gallbladder just doesn't work correctly. It's not excreting the bile the way it's supposed to. Well, if you have a sick gallbladder, it needs to come out too. Not just a gallbladder that's obstructed, which is that inflammatory, we get that common bile duct. If we get a cholangitis, it means not only is the gallbladder inflamed, now probably the pancreas along with the liver. So now we've affected the entire biliary tree. And cholangitis, those people get septic and they die. And then of course mixed injuries. So what do we need to do with that? We need to hopefully figure out what the offending agent is that causes that. How bad that patient is. I'm going to say most of these folks are probably going to go inpatient because we need to continue to monitor and make sure that liver is getting better. You need to maybe see GI or hepatology if your hospital is big enough that you have a hepatologist. And then there's serial LFTs, which needs to be more along the lines of, I'm going to admit them to make sure I got serial liver function tests, serial exams, serial checking whether or not they're altered, whatnot, because we can have something called hepatic encephalopathy. We'll get into that another time as a horrible thing. Questions on that? Definitely make sure that you understand ASTs, ALTs, alk losses. I would definitely read up on that stuff, and I'll give you 2 examples. Any questions right now? Kids, I'll lecture you guys tomorrow at 1500 at the best. I'm doing what my seniors do. 6:30, they just close their computers and stare. Very disheartening. Some of you are going, oh man, I know what I'm going to do. Okay. I'll play your game. Biliary obstruction. So where does the bilirubin go if it's obstructed and can't go down into the cystic duct, into the gallbladder? They eat, gallbladder squeezes, pushes cystic duct into the common bile duct. It's obstructed, so E, right? Because the kidney's got to take over, and it's not getting into stool. Good job. Make sense? Not all rocket science. So what's going to be elevated in obstruction? Am I worried about ALT or AST? Nope. I care about where the outfloss is. I'm simply going to pick the one that has the highest outfloss, which would be A. There's maybe one more question on this whole lecture. It's on the test. Just one more. You'll have to figure out what that is. Okay. I can't chew your food for you, okay, folks? All right, I'll stay around for